Good afternoon and welcome everyone. My name is Brigitte Rose. I'm the Project Coordinator for Rare Lung Diseases here at Lung Foundation Australia. So thank you very much for joining us online for this webinar today, presented in collaboration with our partners at the Centre of Research Excellence in Pulmonary Fibrosis. It's great to see that so many of you were able to come in live for this session today. So welcome all. Before we begin, I would just like to acknowledge the traditional owners of country throughout Australia and their continuing connection to land, sea and community. We pay our respects to them and their cultures and to elders past, present and emerging. Before we begin, there are just a few housekeeping points to run through. So the first one being this webinar will be recorded. So if you do need to leave at any time or if you'd like to refer back to today's session as an ongoing resource as you manage your lung condition, you can certainly do so. The recording will be hosted on our YouTube channel, and if you've registered for this webinar series, you will automatically receive a link to the recording via email as well. Secondly, I will just let you know there is a Q&A session to be held towards the end of the webinar. So we really encourage you to submit any questions that you might have throughout. Please feel very welcome to ask as we go along. The questions will appear in the Q&A box and I will direct them to our speaker at the end of the session, so you don't need to worry about interrupting or anything like that. You can submit your questions anonymously as well, so if there is anything you want to ask without identifying yourself, you can certainly do that too. And so without further ado, I will welcome our speaker for today. Associate Professor Nicole Goh is a respiratory and sleep physician at the Austin and Alfred Hospitals. She's got a particular interest in interstitial lung diseases, and she's the director of the Interstitial Lung Disease Service at the Austin Hospital. She's actively involved in ILD research and focuses specifically on measures improving quality of life, so the role of pulmonary rehabilitation and supplementary oxygen. So welcome, Nicole. If you would like to share your screen and your presentation with everyone joining us today, over to you.
Good afternoon, everybody. Thanks for joining in, and thank you for Lung Foundation for organising these webinars. And I think they've been very well received, and I think this is the end of a series of webinars this year. I encourage you to provide feedback at the end of it so we can actually help design for future seminars or webinars. So welcome to my hideout at home. Some of you might be the same with stage 4 restrictions. So I'm actually at home with my husband and my 2 children, and he's at work and they're at school. So if my internet falls out, Brigitte will be delivering my talk on my behalf. She doesn't know this yet, but she will do it, I'm sure, brilliantly.
Thanks, Nicole.
So I've been asked to talk about understanding palliative care and advanced care planning, and it's really more a bit of a chat. So, and I want to invite you to ask me lots of questions, and it's trying to demystify this area and really have a good going chat. So I'm going to talk about palliative care, and I'm going to talk about what is palliative care. When should we introduce palliative care to our patients? How can you access palliative care? And then I'm going to talk a little bit about end-of-life care, and then going to move on to advanced care planning. And then why do we need to plan ahead? And what is advanced care planning? And how do we start the conversation? What I'm not going to talk about is voluntary assisted dying. So I'm not sure who's actually dialed in, but in Australia, Victoria, that was brought in last year, and it's legalized in Victoria, and I believe it will be legalized in Western Australia, but I won't be talking about that. So before I start, I'd like to show you a little clip from Palliative Care Victoria, and I hope that will come out.
Palliative care helps improve the quality of life for someone living with a life-limiting illness. Illness may limit what a patient can do, but there are many ways we can help. Victoria offers a range of services from inpatient to home and community-based care.
Australia has one of the best developed and advanced palliative care services in the world for community hospital and inpatient palliative care services. But increasingly, people are focusing on management of illness as it progresses chronic disease, non-malignant disease, diseases that need supporting not only in the hospital sector but also in the community sector.
You couldn't wish for better service from anyone, the doctors and the nurses at the hospitals. They've been exceptional.
Services such as Eastern Palliative Care focus on people staying at home as long as possible.
It's our job to provide a comprehensive suite of palliative care services to people that have specialist palliative care needs.
Palliative care services include at-home care, specialist inpatient palliative care, counselling, equipment and aids, volunteer support, and hospital care.
The fact is that people who have symptoms well managed by a specialist palliative care team in the community do live longer than those who don't have that same kind of care, and that's been proven in research.
As well as support from health professionals. For many, the primary carer is a family member.
And when the dad got sick, I'd noticed quite a while beforehand that his health was not quite right. And that's how I sort of become dad's carer.
A range of aids is available to help with moving around and other activities of daily living.
He's got mobility aids to help him, and therefore I can try and help him the best I can. Now he's got his new scooter. It's made things a lot easier for him and me, I suppose.
If you're going up a hill, you've got a little button on it to give you a bit more power into the battery, into the motor. So that's been very good.
Well, for carers, I think at some point, as a carer, you do need some sort of respite for people you're helping out.
Talk with your palliative care service about support and respite care options. Palliative care can be involved early in the illness and at the same time as treatment, such as chemotherapy. Increasingly, advanced care plans are used, where the patient makes it clear in writing the way they want to be treated.
I think it's really important that families talk to each other about what their wishes are at the end of life. So if we don't know where someone wants to die or where they want their care to be delivered or who they want involved, there's a lot of guessing that goes on for families, and that adds to the stress. So having those open discussions, which can often lead to the development of an advanced care plan for people, are really useful discussions to have.
Palliative care services are free or subsidised through Medicare. However, there may be costs involved for some specialist equipment, medications, and treatments. If you do choose private palliative care services, you will need to pay. It's best to ask about costs before you make a decision. Victoria offers home-based and specialist inpatient care where clients receive medical, nursing, social, and emotional support.
My best advice is to engage early, advocate, push to your healthcare professionals to engage palliative care. We need to be part of the team early rather than late.
To find out more, make sure you log on to betterhealth.vic.gov.au/palliative.
So where does palliative care origin? So the origins of palliate really comes from the Latin word palliare, which is to cloak. I guess for me, to cloak is to protect, to comfort. And really, Dame Cicely Saunders was the founder of the first palliative care movement or hospice in the UK. So she really died only 15 years ago, but she made exceptional ground in this field. And this is one of her very famous quotes. So you matter because you are, and you matter to the end of your life. We will do all we can, not only to help you die peacefully, but also to live until you die. I think that's a very poignant quote. So what is palliative care? And so you would have heard a bit about it on the video already, and we thought we might just distill some of the finer points. So it is an interdisciplinary medical caregiving approach, and it's aimed at looking after people living with a life-limiting, incurable illness. So the stress is on an interdisciplinary model of care. And by doing so, we hope to optimize quality of care, not just for the patients, but for the families and for the carers as well. We aim to reduce suffering, and we aim to support them and their carers and their families through these difficult times. So essentially, it is really the whole team for the whole person. So I'm going to talk about a few things, but I want to come back to the interdisciplinary model and the quality of care aspects of this presentation. So we talk about the whole person. What is the whole person? So I guess as doctors, we tend to focus on the physical aspects, so to what drugs we want to give and what symptoms we want to address. But being a whole person is just not just about your physical health. It's also your mental and emotional well-being. It's your social well-being. It's your, it's your interactions with people in your life, and spiritual health. So some people, some people are very much driven by their spiritual strength and their spiritual beliefs. So all these really encompass the whole person health. So I often see people come to me for second or third opinion, and I often get, they tell me, oh, I've seen my doctor and they said that there's nothing I can do for them. And whenever I hear this, this is what I do. I just go, no, it is a recurrent theme, and I cringe whenever I hear this phrase. And in reality, there is always something that can be done. Okay, and I think as doctors, we tend to focus on, on patients' disease, and if the drugs don't work, then we feel that it's futile, and that is so wrong. Medicine is not just treating physical illness, but it's treating all those things we talked about: mental health, spiritual health, and social health as well. So coming back to quality of life, so really we talked about aiming to improve the quality of life. So it is not to prolong life and not to shorten life or hasten life, but to improve the quality of life for the time that is left. And basically is living until you die, to the very last breath. And sometimes you can prolong life because you actually enjoy living. And sometimes we do hasten life because you feel comfortable and able to say goodbye. So how do we improve quality of life? I think first we need to set up realistic goals and aims. Okay, so basically being able to carry out the things that are important to you, helping to set realistic goals, helping to set aims. So what is it going to make your life really worthwhile for you? It might not be, and often we as doctors we think about symptoms, but sometimes it's about reconciliation, getting together family members, or seeing something important to your family members. So it's not always about the physical health that might be the person's goal about improving the quality of life. So we talked about setting realistic goals and aims and working towards those goals. Obviously, as doctors, we also try to improve the quality of life in terms of the health outcomes. So in terms of managing symptoms as well. So you can see in the middle is quality of life, and obviously this is driven by different symptoms. So obviously in lung diseases, we talk about cough and breathlessness quite a lot, but I think fatigue is also really important. And also obviously mental health, including anxiety, depression, and deconditioning is a big thing. So often people with lung disease often feel breathless, and as a result, because they feel breathless, they do less. And the less you do, the more breathless you become. So it's that spiraling, that spiral effect of deconditioning. So whilst all these obviously interact and affect the quality of life, you can also see that they themselves can interact with each other. So if you're coughing, you're going to get more fatigue. If you're fatigued, you're going to get more deconditioned. So all these play together, and at different times of your disease, some might feature more prominently and some less prominently, but you can see they're all intricately connected as well. So who is the whole team? So this is talking about the team approach for the whole person. So the team, I think the center of the team really is nurse. Palliative nurses do an amazing job. They're always on call 24 hours a day, and they coordinate your care with different aspects of your care needs. And then there's a doctor, and then there's a counselor. And you might have a physiotherapist. So there might be people that might help with your mobility, with your mucus production, your mucus clearance. You might get a psychologist. So if you're facing a lot of mental anguish or depression, anxiety, that might help your journey. You might get a music therapist. So music therapy has been shown to really improve quality of life. People that sing, can feel uplifted, and we know music therapy, music itself can increase dopamine levels and endorphin levels, and for some people it really is very helpful. You might get an occupational therapist, so that you might, if you heard you might sort of need aids and equipment, and they can come and assess your house and work out how to get you mobile. How do you make your life in your home comfortable, so that you could have a comfortable time at home. Obviously, if you're having social issues, then a social work might help as well. And so my sister-in-law is actually a massage therapist at the palliative care service down the road, and she goes and massages people 3 or 4 patients a day, and you know, and through massaging, you know, she's able to also interact with the patient and deliver comfort measures. And some people might want to see a chaplain for their spiritual health. Now, this list is obviously not exhaustive, but this is just an idea of what potential you can tap into if you have palliative care service. Again, this is the multidisciplinary approach to palliative care. So this is just I've just plagiarized this really from the Palliative Care Victoria website, and these are the things that palliative care can deliver to you and your family and your carers. And I think it's really important that you can stay at home. So a home-based service where they come to you, and it's a 24-hour access. So you have the peace of mind that someone will be at the end of the line any time of the day or the night, and you can get help. And obviously you can see there are a lot of players in this service, and it's important to coordinate the care of the different health services. Again, we talked about advanced care planning and how they can facilitate that. And more importantly, you know, so as we talked about, it's not just the patient, it's about the family, the carers, so they can provide support groups for your family and your children. And even beyond death, you know, so even when a patient passes on, they can still provide support for the family members that are grieving. So obviously one of the things they'll be doing is offering palliative care physician to support your complex care with your GP. So when it comes to doctors, you know, I think you can look at palliative care doctors as being either primary or secondary or specialist. So primary palliative care physicians are pretty much all doctors. So all doctors are obviously equipped with some basic skills and competency required to provide comfort care, palliative care, and this would include obviously oncologists, but you know, really all primary care clinicians. So whilst palliative care really started off as in cancer care, we know that palliative care really extends beyond cancer. But we all know that as primary physicians, you know, we don't always have the time or the resources or really the knowledge to deliver palliative care effectively. And that's when we have to call upon our colleagues, and that's where palliative care as a service comes to front. So these are specialists who are trained particularly with knowledge and skills to advise on advanced symptom management, be it pain, breathlessness, and also to be able to facilitate communication between the various team players in the palliative care field. So, I mean, so I do a bit of palliative care, but I don't pretend that I'm able to do half of the things that palliative care can deliver. But it's really important to say to your patient, often when you refer to palliative care, people often think that you're abandoning them. So we don't abandon our patients. But what we say to my patients is that, you know, I think that you know, my skill sets are, you know, there's a limit to what I can do for you. And I believe that, you know, that you will gain much more if you tap into a palliative care service, and together I will work with your team to make your quality of life better. So it's important to let the patients know that you're not abandoning them, that you're actually working in conjunction with a palliative care team. Okay, so we talked about, so palliative care was really developed as for cancer care, but we know that there is increasing evidence to show that palliative care do benefit people outside cancer. So with advanced lung disease, advanced heart disease, neurological conditions. So I'll also look after people with motor neuron disease, and palliative care definitely features very high up in people with motor neuron disease. So the benefits are really been proven. It does reduce symptom burden. It improves quality of life, reduces depression, and increases patient and caregiver satisfaction with their care. So they're satisfied and you know, and they're comfortable with the care they're getting. And it may increase survival, as I said, you know, because you actually enjoy living, so you tend to then want to live for a bit longer. It also been shown to decrease burnout amongst other providers as well, which is really important. So, you know, for us to deliver care, we all need to be happy in what we're doing and find comfort and pleasure in helping other people and not get burnt out as well. So really palliative care So unfortunately, a lot of people still think of palliative care as end of life care, but really palliative care should be viewed as supportive care, comfort care, or quality of life care. So really, it's not just about dying; it's about living, until you die, be that weeks or months or years. Okay, so we talked about what is palliative care. So when should we then introduce palliative care? So I guess before we talk about when we do it, so who is it for? We really touched upon this. So we talked about it's for people really with progressive, life-limiting, incurable illnesses, and that's obviously that came from cancers, but it's not just cancers. It's people with neurological conditions. So we talked about people with motor neuron disease, Parkinson's disease, it's heart diseases, liver diseases, kidney diseases, and obviously lung disease. This is obviously where I'm coming from. And I guess as a group, we tend to get people with chronic lung disease, so people like with chronic asthma or emphysema or bronchitis, so people with sort of advanced COPD. Obviously, people with pulmonary fibrosis or interstitial lung disease, of which idiopathic pulmonary fibrosis obviously is one of many forms of interstitial lung disease. So I just want to talk a little bit about idiopathic pulmonary fibrosis. So it is a progressive, irreversible disease, and it has a potential poor survival. So the average survival is about 3 years from the time of diagnosis, although this is probably a bit longer now because so although IPF is rare, I think part of it is people are not aware of this disease, be it whether with doctors or even patients. So I think since we've really tried to increase the profile of this disease, and people are getting diagnosed earlier, but however, the average time from symptom to diagnosis is about 2 years. So really, we need to do a bit better by raising the profile and really getting diagnosed earlier. And we all know that there are now 2 drugs available. So pirfenidone and nintedanib have been shown to reduce the progression of disease and really probably improve survival as well. So this 3-year survival probably is a bit longer now that we have better drugs and we also have a better awareness of this disease as well. So the disease course is variable and unpredictable. So it is progressive, but then it can progress very rapidly or it can progress very, very slowly. Or some people can progress and then they can step down and then plateau again and step down. So that's what we call a stepwise progression. Unfortunately, when we see a patient for the very first time, we cannot predict how someone's going to behave. In addition, there's this phenomenon of acute exacerbations. These are people that for no reason just get an exacerbation, and it's not because of infection or other causes. And unfortunately, once you have an exacerbation, you tend to have a poor prognosis and you are left with quite significant symptoms of breathlessness and cough. And whilst this happens, usually with severe disease, it can actually complicate disease at any course, at any time in your disease course. And we know that IPF is associated with significant burden of the disease, not just for the patients, but also for the carers and the family. And as a result, they have reduced quality of life. So going back to when to deliver palliative care. So this is an old model of palliative care. And when I say old, so obviously this is, we don't favor this, but a lot of people, doctors included, and also patients believe that palliative care really is something akin to end of life care. And so in the past, people would be diagnosed and they would then have disease-directed therapies. And then when that's exhausted and it's generally not effective, and then people turn to palliative care before they die. So previously the model was that of really almost end of life care before the patient died. But there's a big move towards moving away from that. And really the new model should be like this. So you get diagnosed at the start, and then you're given disease-modifying treatment with the intention to cure or slow disease progression down. But really, you should also start the journey with palliative care. So whilst you might need a little bit of palliative care at the start, but as your disease progresses, then you might get less drugs, and then you might get more palliative care. So as you can see, it is a moving target, and it's fluid. So you might not need very much at the start, but at the very end, you might need quite a lot of palliative care, and that's already been introduced, and you know the team already. And then obviously then you get hospice care or end of life care before you die. So really the model should be at the time of diagnosis. Now that probably rarely happens really in reality, but it really should be introduced at an early concept so that you can take it on board, not towards the end, but at least towards in the middle of your journey or early on in the journey. So, and I guess this new model is actually more important for people with idiopathic pulmonary fibrosis. So I think, you know, in reality, people with COPD, we know they tend to live long, but it's plagued with recurrent exacerbations, infections, hospitalization. So they don't necessarily die. They don't necessarily have a shorter survival, but when they live, it's dotted with, you know, lots of symptoms and morbidity. But in IPF, you know, it is, you know, your life will be shortened, and because we can't predict how you're going to behave, and because you could have exacerbation at any one time, it really is in a patient's best interest to be introduced to palliative care very, very early on. Okay, so and I know I bang about this, but it really should be instituted early for the above reasons we talked about. So it is appropriate for people at any age, okay, not just young, not just old people, but any person, even children with life-limiting illnesses should tap into palliative care, and really at any stage in the illness. So preferably early on, but it should not be viewed as something at the end of life. So it can be provided together with curative treatment, and it can run in parallel. And remember that the kind of care that you will need will change as your diseases progresses as well. So you know, so palliative care is so good. So why do we not refer patients to palliative care? And I think because as doctors we don't always know. We don't really know how people are gonna advance or behave, and so it's uncertainty about disease prognosis. And often people might not feel comfortable initiating discussion, so it's a lack of provider skills on the part of the doctors. And in lung disease, you know, the fear of prescribing opioids for fear of respiratory depression, and it's not just the doctors. I think when I broach, morphine to my patients, they often perceive as end of life, or they think they're going to die of respiratory failure, which is not the case. We give opioids really for enough is enough to make you comfortable. And really the doses that we give people are really, are not sufficient to knock off their respiratory centers. So is that misconception and the fear of prescribing or receiving opioids for people with lung disease. Again, there might be limited resources. So in Australia, we're very lucky that palliative care movements are very strong. I know I've showed you a clip from Victoria, but that you have the same resources in the other states in Australia as well. And often as a doctor, people feel that the fear that once you refer them on, you might diminish hope. And I guess from a patient's point of view, you might feel that once we refer you, then we don't have anything to do with you anymore. And that's not the case. It is really a partnership with the palliative care service, and we don't aim to abandon you per se. Again, we talked about misconceptions about palliative care. So it's not just about end of life care. It's really holistic care. For the patient, the family, and the carers. So how do we access palliative care? So really, generally you get a referral from your GP or your specialist or really any other health providers, but don't wait for them to offer it to you. You should ask for it. All right, so you should educate your practitioners, and you should ask for it early on. It's available to anyone with a life-limiting illness, and not just for cancer patients. And most of them are free, but you might have to pay for some costs like medications or aids or equipment or supplies. But you can obviously discuss it with the palliative care team when you need these modifications or supplies. So I was going to show you another video, but I might not because of time. So end-of-life care. So just a little bit about end-of-life care. So palliative, it is a form of palliative care, but delivered in the last few weeks of life, in which a patient with a life-limiting illness is rapidly approaching death. So basically, imminent death. And obviously, the needs are high at this time, and we need to be able to mobilize the services and support to ensure the quality of life is maintained to the very, very end. So it's important to have that relationship with your team and then to be able to increase that towards the end of your life. So getting in early is really important to get that bond with your team. Again, we talked about basic care in a terminal phase, but really this really also extends to, you know, beyond dying. So once the patient passes on, we can also support the people who are left behind. So bereavement care is also part of end of life care. So again, people of any age, and really care is provided where you want it, whether it's at home, in the hospital, in a hospice, or even a residential home facility. So going to advanced care planning. So why plan ahead? So planning your care in advance might make it more likely that people understand what's really important to you. So again, talking about goals that are relevant to you. It makes it more likely that you'll get the care that you really want. And it makes things easier for your family. And even if you're not dying, it can still be helpful to plan ahead. So we plan for life, so we should also plan for death. And it's helpful if there is a time in the future when you can't tell people what you want. So it's about planning and planning. It's about preparing for the worst, but hoping for the best. So what is advanced care planning? So it's really a guide for your loved ones and doctors so that they can make decisions that respect your values and preferences. It can just be a conversation with a trusted loved one. You can also write down your beliefs, values, and preferences, but you can actually document it in a legal document. It's called an Advanced Care Directive. And we'll talk about that a little bit in the next slide. And you don't have to be ill to make a plan. And really, preferably, you should make a plan when you're well. Because when you're unwell, you know, you really can't think straight. So it's best to make a plan when you're well. And you can be done in steps and over time. And you can also change it as your disease progresses. And it only comes to effect if you're unable to make a decision for yourself. So if you're still able to make a decision, you can still voice your preferences. But obviously, if you can't, then your doctors then can go to the Advanced Directive Care Plan. So what is an Advanced Care Directive? So it's also known as a living will. It's written by yourself, and it's a record of your preferences and for future care. It can record the patient's values, goals, and preferred outcomes, or directions about the care and treatments. You can also appoint a substitute decision maker. And again, the directives differ between states and territories, and it's best to go to your state to have the specific forms downloaded. And in fact, you could probably ask your GP or your hospital specialist to help you with this if you want to fill in a form. So we talk about advanced care planning, and it is a difficult conversation to have, even as a doctor. It's often we talk about advanced care planning, but it's even as a doctor, it's very hard to initiate that conversation. But once we get that into the patient's mind, how do you as a patient then start that conversation? So these are just a couple of tips about how to start that conversation. So choose a quiet setting where you will have a lot of time and you won't be interrupted. Be patient and take your time. You don't talk about everything. You can pick about, so maybe I want to have these flowers, or I might want to have this eulogy. So you don't have to talk about everything in one go, and just take it in your own stead. It's an ongoing conversation. All right. So again, so have quiet time, but then you might pick on different things to talk about at different times. And often starting it is quite hard. So what are the things you can try to do? So you might try to think about, I was thinking about what happened to Mrs. Smith, and it made me realize that when I go, I want to have lilies and not carnations. I want to make decisions on my behalf. I would want, Frank, Bill to make a medical decision on my behalf if I wasn't unable to. Being able to, travel the world or to hold my grandchild that's going to be born in 3 months' time is the most important thing to me. And so you work towards a goal. If something happened to me, I would like to, okay, so these are just a few pointers as to how to start the conversation. I don't know whether anyone's actually heard of this. So this is a public engagement campaign that was developed in the US, and it was launched in the US in early 2015, but it was launched in Australia in May 2016. And this is how to start a conversation about advanced care planning. I'm just going to show you the video for the next 3 minutes.
Welcome to Death Over Dinner. You might be asking yourself, what could death and dinner possibly have in common? Or maybe you're wondering why someone would even want to talk about death, especially over an otherwise pleasant supper. Well, here's the deal. The way we die in America, and now in many other parts of the world, is pretty messed up. Not just the fact that we die. End-of-life care is far from ideal, and it causes a lot of bankruptcies. Most people die in hospitals, and they are really expensive. Yet 75% of America says they want to die at home, and only 25% of us do. Regardless of where we spend our last weeks, days, or moments, the thing we are really missing is a straightforward conversation. It's obvious if you think about it. If you don't tell your loved ones what you want during your last mile, you won't get it. Say, for example, you wanted a vacation in Aruba, but you didn't tell anyone, and your well-meaning family booked you a long, costly ticket to Antarctica. Not what you wanted. The default when it comes to dying is also very expensive, and like Antarctica, most likely not what you wanted. Not telling your loved ones what you want only makes everything a lot harder for everyone, emotionally and logistically. They're already going to be devastated by losing you. On top of that, imagine having to make a seemingly endless list of decisions. So we came up with a simple solution: dinner and conversation. Just talking to each other, openly, directly, authentically. Since we launched, there have been over 100,000 dinners in 30 countries. It seems these two things go together quite nicely. So, what happens at a death dinner? It all begins with our website. You tell us why you're interested in having a dinner. And when you select an intention, we magically create a script for your evening. In this script, you will find a series of thoughtful questions for everyone who comes to dinner to consider and answer. If you don't like a particular question, don't answer it, and that's about it. But here are a few pointers. Don't surprise people. Pizza night, surprise, death dinner. No. Don't hog the talking stick. Put that phone away. No one needs you to be checking your Instagram while they're talking about how they want to be remembered. Make something simple. Light some candles. Create the right ambiance. Give yourself plenty of time. Make I statements. This is not an opportunity to argue. There are no experts in death. Listen deeply. Say something you're afraid to say. It is the quickest way to get closer to the people in your life. When you're done, maybe you want to take some next steps and put a few things in writing. Our goal is to change the way we die, one conversation at a time. Join us.
So this is just what I lifted really off the website. So how it works is you go to the website, you ask the host to answer basic questions about the guests and why they are having the dinner. And then it prepares materials for the guests to read, listen to, or watch in advance, which hosts a selection from an extensive library. And then you as the host receive an email invitation and support materials, including hosting tips and icebreakers to get the conversation started. And so when the dinner party starts, then let the wine and conversation flow. So that's the end of my presentation, and I thought I'd just read some resources. So the Lung Foundation has a really good web page about palliative care and support. Obviously, there is a website for advanced care planning, and obviously the two websites for palliative care Victoria and obviously palliative care Australia. But you have the same in your own state as well. So thank you very much for listening, and happy to take any questions.
Thank you very much, Nicole. That was just wonderful. I'm very glad that your presentation held out. I didn't have to jump in at any point, which is great because that was just so valuable, very insightful, and yeah, it's a very sensitive topic, obviously, and I think You've presented so much there, and that death dinner really is quite revolutionary. So I hope our attendees were able to get something out of that today. And now I will just remind everybody, I can see that we've got some questions coming through already. The answers will be of a general nature only, and so we'd certainly encourage you to continue to seek support from your treating healthcare team, as well as the general advice that we'll discuss here today too. So Nicole, the first question for you has come through anonymously. The asker is asking whether or not they can, their family can get support, through the palliative care service. I think that was briefly touched on just at the beginning of your presentation. I don't know if possibly this person missed it. If you wanted to just give a bit more on that.
Yeah, absolutely. I mean, as I mentioned, palliative care is not just about the patients, but also about the carer and the family. So there was a clip I didn't show, but it was they were interviewing Moira and George, and George was telling the audience, how much palliative care helped him, and he was saying that if it wasn't for palliative care, they probably wouldn't be together. So really, as much as it is for the patient, it is also to support the family and the carers as well, and to keep the family together.
Okay, thank you. And another question's come through for you as well. This person's wanting to know how they can know when they should start looking for help as their fibrosis progresses to a stage where they're going to need hospitalisation or hospice care.
So just going back, I think when you say help, I gather you mean palliative care help. So you obviously, I would hope that that you would have been linked in with a good service at your GP or your hospital, and you have the chance to talk to your specialist and or your nurse. And really they should probably start the conversation, but if they haven't, then you need to approach them about palliative care, and to start the journey early. And to be fair, when I broach the subject, most people say, well, am I dying, or are you abandoning me? And it's about telling them no. It's about putting you in it's a collaboration with a specialist service, where people are trained, to deliver combination, to deliver, high sort of advanced symptomatic management plans, and to collaborate your care and coordinate your care, and also to support you, your family, and your carers. And it's all about, it's as simple as getting, a comfortable bed, or a 4-wheel frame, or to modify your bathroom so that you can have a shower. So you should probably ask for it early, and if your doctors don't offer it, you should then institute it yourself.
Thank you very much, Nicole. We've got a few more questions coming through. Somebody is asking, would my specialist recommend palliative services that would be beneficial if I'm not sure what's best?
Well, absolutely. So, we talked about that palliative care, it is a moving target. So, you might be introduced very early on, and it might just be, meeting the team, and you might not need much, so I have patients where I've introduced them and they've met the team, but then they will then call on them maybe once a month and see how things are going. But then if your needs change, so if you need, an aide, or you need to see a psychologist or a social work, that's when then you can tap into the services. So you might not need palliative care, a lot of it at the start, but as your journey progresses, then you will need more and more of their input. And then often when people, it's not, a lot of patients have a lot of carers, not carers, but providers. So they could have, they could have me as a specialist, and then they could have heart problems, kidney problems, and then they have obviously, different people looking after them. So often it's very confusing, and you might miss appointments, and so you need someone to actually coordinate your care and talk to them. So they can also be a service that can actually help coordinate your care and make your life easier. So it's not just about delivering physical care or needs, it's actually delivering social needs, mental needs, music therapy, massage therapy. You get free music therapy, you get free massages. How good is that? Mm-hmm. So it goes far and beyond just physical health, and you should tap into it as much as possible. And it's free of charge in Australia.
Yes, that's great. Bringing it back to that comfort care aspect of it all. Okay, another question for you coming through. I believe this one might be from a healthcare professional. They're asking if you have any tips on engaging their medical colleagues, so GPs or hospital-based, to begin considering palliative care early on into the diagnosis. So this person is particularly asking around advanced non-malignant lung disease.
Yeah, again, it's dispelling the misconceptions. I don't think people, even as doctors, know what palliative care services actually offer. And I think people often think, oh, it's just, maybe treating their cough or breathlessness, but they don't realize that it really goes far and beyond that. So, as I said, the holistic care, the mental health, the social work, the aids. I think I get questions like, how do I get a scooter? And often then I'll put them into contact with my social work at the hospital. But I think if you have a palliative care behind you, a team that's behind you, that you can tap into it. So it's to me, it's a no-brainer. It's basically a resource that can be tapped into on multiple levels. So I think it is telling them, spreading the word about what palliative care really is. And I think a lot of people are not comfortable broaching the subject because patients view it as end-of-life care. So again, trying to educate patients about the fact that this is not about end-of-life care. It is about totality care for the whole patient. So it is raising awareness and educating our patients.
Okay, perfect. Thank you very much. I think that brings us, oh, hold on. We've just had one more question come through, through the chat panel. Somebody is asking, how does palliative care tie in with aged care plans? There is, I understand, a 2-year wait list for a stage 4 aged care plan.
I can't answer to the aged care plan, because I'm not a geriatrician, so I'm not very familiar with the aged care plan, and I'm not quite sure what the stage 4 is either. But I can only speak from personal experience. So, whenever I put in a referral for palliative care, I get a response within 24 hours. So I put in a referral online, and then I get a response over 24 hours to say, I've received your referral. And then often they'll ring me and discuss, so do you want us to go and see the patient this week, next week? So I've never had an issue about patients waiting for 2 years. So I don't really know how that's linked to the aged care plan. I'm sorry, I can't really answer that.
Okay, all right. Thank you, Nicole. I think, Maureen, we will see if we can get you some help offline about that, but maybe worth asking your treating healthcare team. It seems like they might be in separate streams. So I think that's the end now. I think we've gotten through all. Oh, no, I'm sorry. We do have some more questions coming through. As a carer, what would you advise if my partner doesn't feel ready to talk about palliative care? Are there resources, that you would recommend? It's a good one.
Yeah. Is that conversation starter, isn't it? Sometimes you can, you could say, maybe you could say, look, I'm not coping, I love you dearly, and I have concerns about, your health, and, and I need help. Maybe you could turn the focus onto yourself, because palliative care is about delivering, a service, not just to the patient, but to the carers as well. And so you could use it as, I need help. And what do you think can we tap into the service? So you might turn the focus to yourself and not make it for the patient themselves. That's one way of doing it. But like everything else, so when I talk about advanced care plan or even oxygen therapy, invariably the first time I say no, they'll say, no, I don't need it, even though they can't get up, the flight of stairs, or they still no longer can do the shopping. It's a very stigmatized oxygen therapy and advanced care plan, or even palliative care. But if you bring it up repeatedly, and in different settings, so you probably just have to work at it each time, and eventually the penny will fall, and that's when we engage. So so be patient, and just bring it up, on a regular basis, and one day the person will take to it. And I think it's also good to know people that have been in the service. And I haven't had one single patient tell me that they were not grateful for being referred. So they all of them would have had reservations and trepidation at the start, but once they're actually connected, they actually would say, thank you so much for doing that. I didn't realize how good they were. And knowing that they were available 24 hours a day, knowing that there was someone they could actually ring at any point in time, it's actually a great comfort. So I think maybe talking to people who actually have received the care, and I think that's helpful in itself.
Yeah, thank you, Nicole. And we can maybe direct them to our link that I've posted in the chat box for LFA's palliative care resources as well. Would be a good place to start with those conversations. Somebody else has just contributed to that previous question, Nicole, suggesting that possibly the stage for aged care plan might be referring to home care packages, as there's a significant wait list for level 4 home care packages. I'm not sure if you had anything further to comment on about that. It's perfectly fine. If not, we can see if we can get some more information offline. If not.
Yeah, I can't comment on that. I'm really sorry. And it probably has to do with aged care rather than palliative care. Yeah.
Okay, well, I think that's it now. The Q&A box has been cleaned out. So thank you very much for that, Nicole. We really appreciate you joining us today, and especially touching on this content that in the past we don't have a lot out there on it. So there's been a huge gap, and you've really helped to fill that for us today. So thank you very much for coming along. Thank you very much to our participants as well. There were some really insightful questions, and again, it was really lovely to see so many people dialing in live. We do have some more pulmonary fibrosis resources on our website as well, so we encourage you to visit those. And if you did have any further questions or needing more support after this today, then the Information and Support Centre is here to take your calls via the details that you can see on your screen there. So that brings us to the end of today's presentation. Thank you very much, everybody. Take care of yourselves and each other, and we'll see you next time.
Thank you, Brigitte and Lung Foundation, for hosting this. Thank you.